Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meeting in our usual time, Wednesday, 9 p.m. every week as usual. Today is CKD bone mineral disease day. Our meeting today is specialized for this, and this is our lecture. And of course, when we mention CKD-MBD, we are to go to Professor Amr al-Hussein, who I am shared, who is sharing to me, and I am so pleasure to co-share this session with him today. Professor Amr is one of our dear colleagues. He is one of Mansoura University. He received his MD from Mansoura and received from his residency and training in Mansoura University. And now in USA, in University of Kentucky, he is the professor of nephrology and medical director in University of Kentucky, USA. Professor Amr is known by his interest in primarily in PMD and many aspects of nephrology, especially GN, glomerulonephritis. And if you look for in the PubMed and search for Amr al-Husseini, you will find more than 110 publications named by Amr al-Husseini. So we are so lucky today. We are really pleasured and honored to have him in our CME meetings in a continuous way in Egypt, and he is joining us in all our educational activity in Egypt. In addition to all of this, Professor Amr is working as Vice President of World Kidney Academy and the Director of glomerulonephritis and CKD-MBD fellowships of this, and he is now designing new fellowships in World Kidney Academy. So welcome, Professor Amr, on board in this meeting and your special interest in CKD-MBD. Coming to our speaker today, we are lucky to have Dr. Rasha Darwish, my dear colleague and friend in Cairo University, and she is doing really a very good job today in representing Egypt internationally, as soon after she got her MD some years ago, she stressed on this aspect to represent Egypt in international society. Nowadays, Rasha is the PD Committee Chair of African Association of Nephrology, AFRAN, and she is the treasurer, one of the EXCOM and of AFRAN, African Association of Nephrology. In addition to this, she is ISPD nominating committee member, Francophone. She is also ISN dialysis working group member and one of the active group. And lastly, now she joined European Renal Association as the only non-European member in Better Kidney Health Working Group. So I will leave the floor for both of them. Amr, please start this session, and I expect from all attending professors to have a very scientific and very fruitful discussion later on. And Rasha to introduce her lecture, CKD-MBD overview. And before I leave, I would like to thank Dr. Abdurrahman al-Maghrabi, our coordinator today, for his work regarding this session and all of his work regarding CME chapter active. So please, Professor Amr, start.
Thank you so much, Professor Yasser, for this nice and informative, very informative, actually, introduction. I'm here to learn from Dr. Rasha Darwish. I get to know her through Dr. Ahmed Halawa, I think, a year ago, and I'm following her achievements and progress in different societies. And I'm very sure that we will have very, very fruitful and thoughtful lecture and discussion today.
Please, Dr. Rasha, start.
First of all, I would like to thank Dr. Yasser, my dear colleague and friend, for giving me this chance to talk in my house, in my home, Egyptian Society of Nephrology. I'm very proud to be among all of my colleagues and professors, and Dr. Amr for giving us the time to be present in this session, since he is the guru of CKD-MBD. So we are very, very lucky to have you with us today, Dr. Amr. I will try to cover the subject in a more or less simplified way, since it's a very big subject. And I will try to cover it in the way that I prefer usually, to try to cover the pathophysiology, what's happening in the roots, and how we can try to connect that to our clinical approach to the patient, which is at the end, I think, what really matters for us clinicians. I will talk about, first of all, the introduction about CKD-MBD. Actually, the fact that the bone in particular, the bone biology, the progress of our understanding was one of the most dynamically regulated organs for us to understand throughout history. I mean, its role has developed in a way which is really, really kind of amazing. If you look at history, especially of vitamin D history, the first time it was ever mentioned when in 1645, Daniel Whistler spoke about rickets and mentioned it and described it. And it ended in 1984 when we discovered the activated vitamin D receptors. But if you look at the history of the bone itself, the discovery of vitamin D was done in 1920. And then the molecular structure was described in 1932 by Adolf Windaus. And the relationship of the bone and the kidney was described only in 1968, where it was discovered the activation of the vitamin D in the kidneys. And the presence of this vitamin D in other tissues was in 1969. And finally, vitamin D coplayers were discovered, where actually FGF23 and clotho were described in 1997, and I will mention that in my presentation today. Regarding also the timeline of the evolving understanding of the relation of the bone to that of the kidney function, it started, as we mentioned, with rickets, and then we had its description of albuminuric rickets in 1883, where it was the first time they found that it's not really and then renal osteodystrophy as a term was described in 1942. And then we had the ISN in 1961, starting to work on it. And we finally had the KDIGO CKD-MBD with all the different guidelines that we're going to mention today in 2007. So what is the significance of this nomenclature change? Why did we change the name of CKD-MBD? It was first renal osteodystrophy. And it was described as a constellation of bone lesions which affected patients manifesting these symptoms: bone pain, muscle tendon rupture, and pruritus, and also a very high incidence of fractures. But actually, a vital extraskeletal manifestation was found in this patient, and we're talking about cardiovascular calcification, which, as we all know, is associated with a very high morbidity and mortality rates. So this term was removed. And for us to better describe the systemic disorder of mineral and bone metabolism due to CKD, the term CKD-MBD appeared. And why is our understanding of CKD-MBD especially important in low and middle income countries to which we belong? This very interesting paper about screening for kidney disease in low and middle income countries, done by many nephrologists, including nephrologists from Africa. It first said that the kidney disease, as we all know, is the 10th leading cause of death worldwide. And it disproportionately increases morbidity and mortality for people residing in our region, in low and middle income countries. And if you look at this very, very interesting slide, we see that out of the 41 million deaths worldwide, 71%, 15 million of these deaths are premature, where actually they die pretty early. And we know that the big five of these non-communicable diseases include cardiovascular disease. And we know that the major cause of death of CKD is cardiovascular disease. And the bad news is that CKD is rising rapidly. So what about this CKD? What is the percentage of the world? If you look at the 697 millions of CKD patients globally, most of them, 544 millions, are present in lower middle income countries. And the worst thing is that not only it's more in our countries, but also the age of onset is lower in our countries, where the age of onset of CKD is 20 years earlier in people of African descent, meaning that in our region, we'll have more death and more death of the young, which is a catastrophe. So let's go to the definition. What is mineral and bone disorder, MBD? We have a general definition. The general definition, a systemic disorder of mineral and bone metabolism due to CKD manifested by either one or a combination of the following: abnormalities in labs, calcium, phosphorus, PTH, or vitamin D; abnormalities in the bone turnover, mineralization, volume, linear growth, or strength; or vascular or other soft tissue calcification. And here we see the difference between definition of CKD-MBD and definition of renal osteodystrophy, which is only part actually of the CKD-MB, where actually it's alteration of the bone morphology in the patient with CKD, and we can measure it. Actually, it is quantified by histomorphometry by doing a bone biopsy. And this complication of several actually abnormalities, which are laboratory abnormalities, bone abnormalities, and vascular, leads to cardiovascular diseases, fractures, and mortality. And let's approach each one of these abnormalities. We'll start by what are the abnormalities in the labs in the CKD-MBD. And for us to understand the labs, we have to go back to the basics, where we all know that the PTH is secreted, and it acts on the bone to increase both the phosphorus and the calcium in the circulation. And it also acts on the kidney, but also to increase the calcium reabsorption, but to increase the phosphorus excretion. So it works in a different serum calcium. So PTH works by a way which is at the end increasing serum calcium and increasing serum phosphorus. So the low calcium and the high phosphorus will stimulate the PTH release and vice versa. What about vitamin D? Well, vitamin D, well, actually, it is activated in the liver, causing 25-hydroxylated vitamin D. And then we know that it is activated as well in the kidney, causing the activated calcitriol. This one will work on the intestines, and its action on the intestines is actually very similar, or is the same as the action of the PTH on the bones, which is what? Increases reabsorption of calcium and phosphorus, leading to increased phosphorus and calcium in the circulation. So vitamin D action increasing serum calcium and phosphorus. So the only one which is actually decreasing the serum phosphorus is the PTH via its action on the kidney. What happens if we have CKD or disease in the kidney? Well, actually, first of all, we don't have activation of the vitamin D in the kidneys. And also, we don't have reabsorption of calcium in the kidney, nor secretion of phosphorus in the kidneys, resulting in what? Resulting in decreasing in the serum calcium and increasing in the serum phosphorus. And if you go back to the origin, these two were the actual stimulator of parathormone. So we will have increased production of the PTH, causing secondary hyperparathyroidism. This will affect the bone and cause bone disease with manifestations of fractures, bone pain, myelofibrosis, and even erythropoietin resistance. Well, if this low serum calcium and high serum phosphorus are persistently untreated, what will happen is that we will have persistent parathyroid stimulation. And this will lead to a marked increase in the PTH formation due to the formation of parathyroid adenoma, which is a condition that we know as tertiary hyperparathyroidism. And this affects the bone because at the end, it would cause resorption of the calcium from the bone and cause at the end increase in serum phosphorus and serum calcium in the circulation. If you go back one step to the step where we had secondary hyperparathyroidism, what they found, as I described, is that the increased serum phosphorus caused the increased production from the bones of the fibroblast growth factor 23, FGF23. What does this FGF23 does? Actually, its main role is to increase secretion of the phosphorus via the intestines and via the kidneys. But when we have chronic kidney disease, well, actually, what happens is this phosphatic excretion via the kidney is not happening. So we have persistent elevation of the phosphorus level in the circulation. And this will, by its turn, persistently stimulate the bone to produce the FGF23. So we will have a persistently very high level of FGF23 in CKD. And this is by itself a very strong independent predictor. So if we look at the labs, in mineral and bone disorders, in secondary hyperparathyroidism, as we understood, the PTH is high, the calcium is low, and the phosphorus is high. And in tertiary hyperparathyroidism, the PTH will be much higher. The calcium then will manage to be actually normal or even high, and the phosphorus will be much higher. And what is important to look at is the bone-specific alkaline phosphatase, which will be elevated in both cases, which is reflecting the bone resorption. Well, now let's look at the other very important part of the CKD-MBD, which is the vascular calcification. We all know that we have an elevation of the calcium and the phosphorus byproduct, and this causes deposition of these byproduct in the blood vessels, in the joints and extra-articular soft tissue, causing, as we know later on, calcification, and also under the skin, causing the very, very disturbing pruritus that these patients are complaining of. And these are different images showing in the first one arterial calcification, where the blood vessels seems very clear because of the calcification. We can also have pulmonary calcification, the second one, and we can have periarticular calcification around the joints happening in these patients. But however, in the recent years, the main focus has switched from the exclusive safe control of the calcium calcitriol parathyroid hormone axis to prevent and treat secondary hyperparathyroidism, to actually include the novel and complex endocrine axis involving FGF23 and renal growth. And this is about, this is just showing how it is important and how it is regarded as a biomarker of cardiovascular risk in CKD. If you go back to this slide where we showed that the persistently high phosphorus caused a persistently very high level of FGF23, and we said that it is a strong independent predictor of mortality in CKD. Why? Actually, it was found that the tone of this physiological talk between the kidney and the bone was too loud, and it leads to problems on the long term on the bone itself and the bone marrow, on the blood vessels, as I mentioned, and on the heart. Actually, if you can see that this happens very early, and this diagram is very interesting because it shows in the green the hyperphosphatemia level, the yellow second hyperpara, and the blue the level of FGF23 excess, and it is shown in relation to the estimated GFR. And as you can see, actually the dark blue, which is reflecting the FGF23, rises actually pretty early, even before secondary hyperpara and hyperphosphatemia, which is a bit strange because we just mentioned that the high phosphorus was a major cause of the elevation of FGF23. And I'll come back later to say that the elevation of FGF23 is multifactorial, not only caused by the high phosphorus. So if you look at this drawing where it shows that this FGF23, which is secreted by the osteocytes and the osteoclasts, have actually many factors controlling it. The high phosphorus, but also the high PTH is one of the regulators. High calcitriol regulates high calcium. Also, it is regulated by what? Iron deficiency, EPO and hypoxia, and even inflammation state and insulin and leptin. So the FGF23 is not only secreted or stimulated by the high phosphorus, but many other factors which are unfortunately present usually in the CKD, even in early stages. So when we look at the FGF23 and the kidney bone crosstalk old theory, the old theory was claiming that we had high phosphorus. The high phosphorus will cause as a positive feedback elevation of PTH to get rid of this phosphorus. And we have a positive feedback to decrease the low calcitriol, and thus we have a low calcium. But what was found that even in early CKD, the low calcitriol was found before the high phosphorus. So something was wrong. So the new theory, which was suggested, is that the elevation is caused by another early produced substance, which is the FGF23. So the new theory is that we have early high FGF23 due to multifactors that I mentioned. This will cause a low calcitriol as a negative feedback. This will cause a high PTH as a positive feedback. And we can have in this state, especially if the patient is intake, a normal calcium and a normal phosphorus in these cases. Another very important point is that FGF23 cannot work alone, but it has to work with clotho. What is clotho? Well, clotho is a co-receptor to the phosphaturic responses of the FGF23. It is also a longevity gene that everyone is looking for these days, how to live longer. So clotho is a star. And FGF23 requires clotho for receptor binding. So they have to work together. Well, another very important role of the kidney is that the kidney has the highest level of clotho expression and is a major source of soluble clotho. So when we have renal failure, what happened in CKD? Well, the actions of clotho are all affected, which are many. It actually suppresses insulin. It has a tumor-static effect, antifibrotic, inhibits TGF-beta, suppresses the WNT signaling that we're going to talk about, and thus inhibit also cell senescence. As we say, it has an anti-aging property. Inhibits the expression of the interleukin 6 and 8, and has also a cardioprotection. So again, by having CKD and diminished production of clotho, not only we have diminished action of FGF23, which is depending on it, but also we're losing the clotho effect, which one of them is cardioprotection. So we're having more chances of having heart diseases in this patient. So when you look at the FGF23 many actions, well, first of all, as we mentioned, the FGF23 has a phosphaturic action where it promotes the loss of the phosphorus through the urine. Where does this happen? It happens in the proximal tubules via a sodium phosphate transporter. And then it also acts in another place. The FGF23 acts on the distal tubules by causing calcium and sodium reabsorption in the distal tubules. So this will result in salt and water retention, and also it will cause increased calcium level. So these two factors will cause vascular calcification. So FGF23 causes increased level of calcium with increasing chances of calcification, and also due to the salt and water retention, we have additional strain on the heart by the salt and volume retention happening in this case. The end result, vascular calcification, can be caused by FGF23. Also, another fact which is happening and stimulated by FGF23 is the production of interleukin 6 and CRP, causing chronic inflammation, and we all know that this also promotes vascular calcification. And finally, also FGF23 causes also effects on the blood vessels and the heart, because at the end, it decreases the transformation of vitamin D, it inhibits it thus, and we all know that diminished level of vitamin D has its negative impact on the blood vessels and on the heart. Finally, another action that clotho is having, not clotho, I mean FGF23, but clotho independent, is that it acts directly on the heart. How? It causes left ventricular hypertrophy by causing smooth muscle cell proliferations. So as you see, FGF23 affects the heart and the blood vessels in many pathways and different ways, depending on clotho or independent of clotho. What about the effect of FGF23 on the bone? Well, actually, it inhibits the mineralization, because we know it inhibits calcitriol. So again, it doesn't only affect in a negative way the blood vessels, but also it affects in a negative way the bones in the CKD. So FGF23 affects many different organs. As we mentioned, it affects the kidney, and we talked about in details. It affects the PTH production, it affects the heart, it causes inflammation in the body, including the lungs, and it also diminishes the immunity because it affects the vitamin D stimulation. It even affects the brain. So FGF23 presence affects many and most of the organs, especially in CKD. Now, we know why in recent years there was a focus on FGF23 and renal clotho. But also, we cannot speak about them without mentioning also two other very important factors, which another very important novel and complex endocrine axis involving sclerostin and DKK1. What are these? Well, actually, there is also a sclerostin and DKK1 and a kidney bone crosstalk effect. How? These two are actually among the numerous WNT wingless inhibitors. What are they? Well, actually, these are a family of secreted glycoproteins, and they trigger multiple cascades, as we can see in this drawing, which at the end affect mainly, for our case, tissue generation. So what happened is that they discovered that this group of glycoproteins, especially when they are connected to the pathway or the signaling pathway involving beta-catenin, is connected to the pathogenesis of the CKD-MBD. How? Well, actually, these sclerostin and DKK1 are secreted by the bone, the osteocytes. What happens? Specific stimulation, including mechanical stimulation, aging, or CKD, promote the osteocyte to produce the sclerostin and DKK1. And we have to focus on these stimuli. Yes, we're talking about CKD, but in aging and also mechanical stimulation, these also promote that, and we'll mention that at the end because it might be used in other applications. Now, we have CKD promoting the osteocyte to produce sclerostin and DKK1, and this one, as we mentioned, inhibit the WNT, and this one, they will inhibit them on the osteoblast precursors, causing at the end inhibition of the bone formation. So these sclerostin will cause inhibition of bone formation at the end of the way. Another effect also, it was found that it promotes also a mechanism via the WNT, causing at the end vascular calcification. So again, these two are included in the pathogenesis of CKD-MBD. And as you can see in this drawing, where all the different factors involved in the bone remodeling, sclerostin is involved, where it inhibits the pre-osteoblast to transform to osteoblasts to promote the bone forming. So also Dr. Yasser, Dr. Yasser. Yes, thank you.
Right.
Okay, another important also fact about sclerostin and DKK1 is that we also know, we just mentioned that CKD-MBD develops actually pretty early in the course of the disease, and it is detectable in the stage even 2 of CKD-MBD. And there is increasing evidence that actually circulating WNT signaling inhibitors that we just mentioned actually may play a crucial role in CKD-MBD. Why? Because they were discovered to be present pretty early. As we can say, very early in CKD, even in stage 1 and 2, it was sclerostin was elevated in CKD patients, and it was promoted by the rheumatoid toxins to be produced. And that's why actually antibodies neutralizing these WNT inhibitors may be an appealing strategy to prevent or treat CKD-MBD in the future. And since we know that the osteocytes are the one producing both the sclerostin and the FGF23, as we mentioned, so the osteocyte became a therapeutic target in the treatment of osteoporosis. Now let's move to the third arm of CKD-MBD, which are the bone abnormalities. We all know that the bone abnormalities are controlled by the TMV classification system, which has turnover, mineralization, and volume, where we have different degrees of each in different aspects of the CKD-MBD diseases. These are the major types of renal osteodystrophy diseases, where we have different turnover, mineralization, and volume. We have osteolysis fibrosa, which is one of the most common, where we have a very high turnover with normal mineralization, and usually it results in a normal high bone volume. We have adynamic bone disease, which is increasing nowadays and found more in clinical approaches of different nephrologists, where in these adynamic bone diseases, there is no turnover, no action of osteoblasts or osteoclasts at all. Despite that, we have totally normal mineralization, and the volume in the cases of dynamic bone disease will be low to normal. Osteomalacia, where the turnover is normal, but the problem is in the mineralization deposition of the minerals inside the bones. And in these cases, the volume might be low to medium. One of the very also common found types of renal osteodystrophy is mixed osteopathy, which may be a mixture of osteoarthritis fibrosa and dynamic bone diseases, where we will have, in such cases, normal to high turnover, depending on which of them is predominant. Also, we might have an element of osteomalacia where we have abnormal mineralization in this case, and the volume will be low to normal. And finally, we might have osteoporosis where turnover and mineralization will be normal, but the volume, the total volume of osteoporosis and the protein production in the bones will be diminished. So how actually to diagnose the different types of renal osteodystrophy? It's by biopsy and bone history morphometry. This is the typical way of knowing these different types. But the biopsy, the beautiful biopsies, we can show the different osteoids and show clearly mineralization by using the tetracycline labeling and the amount of osteoid also present and the different shape of the trabecula. All of these morphological changes are beautiful. Yet, in clinical settings, a bone biopsy is not frequently utilized. Why? Because it's an invasive procedure and it's a difficult one. It requires highly skilled personnel to interpret the tissue samples. And also, bone remodeling is a very dynamic process. The average remodeling cycle of 3 to 6 months occurs for an area of bone. And this means that we will need multiple bone biopsies as a gold standard for diagnosing and monitoring renal osteodystrophy. And this is not actually practical. So with time, that's why KDIGO guidelines recommended the dependence more on the trends of the PTH, the serum phosphate, calcium in conjunction with the total or bone-specific alkaline phosphatase as the markers or as markers of bone turnover to guide us for the treatment of mineral bone disease, since very high or very low levels of these markers correlate with underlying bone turnover. To support that, actually, the KDIGO group conducted one of the largest bone biopsy studies involving 492 dialysis patients. And in their analysis, both intact PTH and whole PTH were found to remain significantly predictive in differentiating high from non-high bone turnover. And also additionally, decreased level of PTH with pari-calcitol therapy were significantly associated with decreased cardiovascular hospitalization. So this proved that this actually. So what do we look at? We look at the PTH level and see in which area are we. Either we are very low turnover bone disease if the PTH is lower than 150, or high turnover bone disease if it's above 300, which is usually osteoarthritis fibrosis cystica. We can also have mixed lesions, especially when we have normal bone formation from PTH is from 150 to 300 as a reading. When we have very high PTH, usually in these cases in osteoarthritis fibrosis cystica, we'll have increased bone resorption and formation, increased number of osteoclasts and osteoblasts found in the biopsy, and increased of woven bone and peritrabecular fibrosis. And these are the different X-rays that we have all seen with the characters of osteoarthritis fibrosis cystica, showing in this one the brown tubules, and also the salt and pepper appearance, which is seen in the skull, and the rugged jersey spine with the ridging present in the vertebra in osteoarthritis fibrosis cystica. Clinically, the patient, as we all know, will come with bone fractures, bone pain and discomfort, and metastatic calcification. While if the patient has a very low PTH, we'll consider him have a low turnover bone disease, where we'll have low or absent bone formation, and in biopsy we'll have paucity of bone-forming osteoblast and bone-resorbing osteoclasts. Usually it is caused, in the past, it was caused by aluminum toxicity, but in the present, it's usually more by us physicians by overtreated hyperparathyroidism. How can we doubt clinically? As we mentioned, low PTH, but also low alkaline phosphatase, bone-specific alkaline phosphatase in particular, and high calcium and phosphorus, since it cannot be incorporated into the bone because there is no action happening there. And the results will be due to the high calcium and phosphorus that will have high incidence of tissue calcification. The CKD-MBD management target of the biochemical or these different laboratory parameters. What they are recommending according to the stage, when we are in CKD stage 3 to 5, not on dialysis, that we try to maintain the phosphorus and the calcium within normal range, while the PTH, the optimal level, is actually not known. When we're talking of the CKD stage 5, they are also targeting or recommending to keep it towards the normal range regarding the serum calcium and phosphorus, but the PTH, the range, they are recommending it to keep it in about 2 to 9 times the upper limit of the normal for the assay, which is a very huge range. So what they were suggesting is that actually we focus on the extremes of these PTH, whereas, as we mentioned, this is where we actually should focus in our management. Regarding how frequently we should do these tests for these patients, what they are recommending, depending again to the stage, that in CKD grade 3A and grade 5D, we can base it actually depending on the magnitude of the abnormalities and the rate of the progression. So it depends on the clinician point of view. But if we are in different stage where CKD grade 3A or 3B, then calcium and phosphate every 6 to 12 months, while PTH is based on the baseline level and CKD progression. It doesn't have to be done according to them frequently. While it's CKD grade 4, calcium and phosphate every 3 to 6 months, so it's done more frequently. And the PTH now would have to be done every 6 to 12 months. CKD grade 5 and grade 5D, calcium and phosphate every 1 to 3 months, every month or 3 months, and the PTH every 3 to 6 months. Grade 4 and grade 5D, now we have to aid alkaline phosphatase activity, which is done at least once a year, and more frequently we'll have to do it if we have elevated PTH. And for patients actually receiving treatment, for those who have CKD-MBD and who are receiving treatment, and whom biochemical abnormalities are identified, we can actually increase the frequency of the measurements to monitor the trends and the treatment efficacy. So again, we have to kind of judge according to severity of the condition and our clinical sense in these cases. So therapeutic decisions must be based on trends rather than a single laboratory value. We look at things together, a trend, not just a laboratory value. And also the frequency is based on the presence and magnitude of the abnormalities and the rate of progression of CKD, and also to monitor for trends and treatment efficacy and side effects. So this is the rule about how frequently we do the tests in these patients. What about imaging? Well, actually, our major target of imaging in patients of CKD-MBD is to assess fracture risk in these patients. And if we see the imaging trying to reflect the bone density compared to the decline of GFR in this drawing, as you can see, the white color is normal bone, the gray one is osteopenia, and the dark one, the black one, is osteoporosis. And as you see, while we are moving toward the left, we can see that the normal bone, the white part, is decreasing, so less and less patients have normal bone. We can see more and more bones can develop osteopenia, and we can see as well that we have development of a percentage, not a bad percentage, of osteoporosis in the patients the lower their GFR becomes. And osteoporosis in general, if you compare it to other major problems that we meet in the clinics, like, or actually in the practice, like heart attack, stroke, breast cancer, prostate cancer, osteoporosis and osteoporotic fractures are much more frequent. So they are there. And the problem that these fracture is actually connected to increased severity and increased risk of mortality. So that's why it's very important to be able to diagnose the presence of osteoporosis in patients of CKD, because this predicts their mortality, and we have to treat them as soon as we can. How we can assess the fracture risk in these patients? Well, mainly by 3 different ways I'm going to speak about: bone imaging that I just mentioned, serum biomarkers that we have, markers we are doing in the practice is the PTH, the vitamin D level, the total and specific or bone-specific alkaline phosphatase, and other biomarkers are mentioned. But speaking of these laboratory biomarkers, not all of us have actually the availability of bone-specific alkaline phosphatase. And in such case, as one of my dear colleagues mentioned, it is wiser then to do it with the GGT to know if these alkaline phosphatase, if a GGT is normal, then it is not of source from the liver, then we can rely on the total alkaline phosphatase to monitor our patients. But regarding the bone imaging, what is usually done is we do the DEXA scan. So the DEXA scan, the bone mineral density is measured, and it measures these different structures. But the fact is that the value of the bone density measurements were found not very actually effective in differentiating the different types of renal osteodystrophy. As you can see, I mean, normal CKD-MBD is present in normal bone, but all the rest are actually more or less similar. And that was the reason why actually KDIGO in 2009 was seeing that in patients in advanced stages of CKD, that actually it's not important, it's not to be done routinely because it doesn't predict actually the fracture risk in the general population. So that was their recommendation. Yet, in the last KDIGO recommendations, they suggested that the bone mineral density testing to be used to assess the fracture risk if results will actually alter therapy. So what happened? If you look at the different recommendations, even the WHO-based recommendations, what they were saying that we can use it, DEXA scan, as long as the we are in G3 and the CKD stage 3. But then they saw in the past that it wasn't very useful in stage 4 and stage 5. KDIGO, as I mentioned, was only actually recommending in stage 1 and 2, but not after it, as we just mentioned. But then in 2017, they recommended that, again, we can use it in the early stages, but that we should do it in patients with evidence of CKD-MBD or who have risk factors for osteoporosis. So these patients, in particular, we should do the DEXA scan because it will help us to assess the fracture risk, and it will affect our impact in the treatment decisions in these patients. So we do it if we have proofs of CKD-MBD, and we do it if we have risk factor for osteoporosis, like a menopausal woman, like a person who is not moving, like a person who's taking steroids, whatever we see according to our recommendations. If we find this patient, then we should do a DEXA scan. And what was the rationale? They found that actually, if these patients have a lower DEXA scan, then it predicts an incident fractures in the patients in late stages of CKD-MBD. And this might actually change our decision because we might need to take a biopsy to be sure of our diagnosis. So that's why the KDIGO in the recent years decided that we should do a DEXA scan, especially in suspected patients, because this might lead us to take a biopsy, which, as I mentioned, is a very invasive procedure because it might affect my decision for treatment. And I will mention this later on in details. Also about the bone imaging, another bone imaging is high resolution peripheral quantitative CT. Why do they recommend it? Because actually DEXA scan cannot actually distinguish between the cortical and the cancerous bone, and it cannot assess also bone microarchitecture or bone turnover. It allows us to have a non-invasive three-dimensional evaluation of the bone microarchitecture. But again, we are not in the place where it's really available in clinical settings, and we don't have enough data evaluating these techniques. And I would love Dr. Amr, after we finish, to talk to us about the different imaging techniques, because he's the guru in that part, like also quantitative ultrasound or different imaging techniques for us to be able to evaluate CKD-MBD. Also regarding the other biomarkers which were mentioned, like the serum C, telopeptide, CTX, or the PINP, which were both the first bone marker for bone resorption, and the other one, the preferred bone marker for bone formation, were actually, since they were both cleared by the kidney, so they weren't very effective in CKD. And that's why the TRAP5B, which is actually an osteoclast cellular marker, was preferred because it provides a better discriminatory data on the turnover, and it is not cleared by the kidneys. It's one is preferred, but again, it's not present in clinical setting in most of the places that I know of. Finally, there is the FRAX. What is the FRAX? It's fracture risk assessment sheet, which is actually, it's a system where actually it can estimate the 10-year probability of hip fracture and major osteoporotic fracture for untreated patients between the ages of 40 and 90 years. But actually, it doesn't include any adjustment or risk according to the GFR. And the question, is this actually viable or practical in CKD? Well, actually, they said that the FRAX predicts the fracture risk in patients with chronic kidney disease, and they found that actually it predicted the risk for major osteoporotic fracture and hip fracture in all GFR strata. So it is pretty wise to use it in our patients. Also, regarding the imaging, it's very important to have the vascular assessment because, as you mentioned, vascular calcification is always happening in CKD and MBD, and we have to detect it as soon as we can. We can detect the arterial stiffness, or we can make a CT, also arterial and vascular calcification can be seen. We can make a lateral abdomen X-ray where we can see the calcification in the X-ray. Echocardiography, of course, we can help us to see calcification. Also, arterial occlusion can be detected by angiography, Doppler and Dopplex. But in general, what was recommended by the KDIGO is that in patients with CKD stages G3A and G5D, usually a lateral abdominal radiograph, it can be used to see if we have, like, for example, like abdominal aortic calcification, or even also a femoral border calcification can be used. It's a very simple and cheap way to detect calcification. And an echocardiogram also can be used also to see if we have valvular calcification. And these are reasonable alternatives to CT. Especially CT is expensive, and we all know that the exposure to irradiation in CT is much higher in comparison to other ways. So it's practical, cheap, and less harmful for the patient. So now that we mentioned the diagnosis, what is our management? And the management includes mainly prevention, which we all prefer, because preventing is always the best way. And finally, the treatment. So the essence of CKD-MBD management is largely to prevent the adverse consequences associated with secondary hyperpara. And one of the interesting facts is that although the hyperphosphatemia has been linked to several adverse clinical outcomes, there is no evidence to show that normalization of phosphorus level with medical treatment improves patients' outcomes. So what do they mean is that according to the recent randomized clinical trial, there were patients with high phosphate, and they significantly decreased it with treatment, but they didn't find a significant decrease in the level of FGF23, and there was worsening of the coronary calcification scores in the patients that were given phosphate-lowering therapy. This means that it's better to prevent the hyperphosphatemia than to wait for the hyperphosphatemia to happen and to treat it. So the KDIGO recommendation was that it's better to prevent hyperphosphatemia, especially in patients with CKD stages G3A to G5D. And this may be more important than treatment or normalization of the phosphate level. So prevention is better because maybe after you wait for the high phosphate to happen, then you'll have other mechanisms which will cause then chronic inflammation and calcification, and then it might be too late to prevent the long-term cardiovascular complications. So to prevent the hyperphosphatemia, it includes dietary restriction of the phosphate, use of phosphate-lowering agents, and dialysis for patients with CKD stages G5D. Regarding the dietary restriction of the phosphate, what they are recommending that we should try to limit the daily phosphate intake to less than 800 milligrams per day, and you can try to do it by trying to take diets containing not containing carbonated beverages, and also any kind of food with phosphate additives. But the problem is that most of the foods that are high in phosphate are also the major source of protein. And we all know that sarcopenia is one of the major problems that we are facing with our patients, especially on dialysis patients. So it's pretty challenging to try to limit the phosphate in the diet and still to have these patients not developing malnutrition and low protein intake. Also, the type of dietary source is very important when we are telling them the recommendation, because the intestinal capacity to absorb these phosphorus vary from the type of the source of the phosphate. Like, for example, if we're talking about additives and beverages like carbonated soda, the intestinal absorption rate will be from 80 to 100%. So it will be absorbed much more than if we take, for example, the phosphate from a plant-based, like nuts, for example. The absorption will be 20 to 40%. So it's not just phosphate restriction, it's also what type of food containing phosphate you are recommending your patients to take. The other way that they are recommending to approach to prevent the hyperphosphatemia is adequate dialysis. So the type of dialysis, the session length, and dialysate all will determine how well we are removing the phosphate. They are recommending that it should be 4 hours, a frequency of 3 times per week, and this will remove an estimate of 2.3 to 2.6 grams of phosphate per week. While if it is increased to 8 hours 3 times per week, the amount of phosphate removal will increase from 3 to 3.6 grams per week. And on patients on PD, an estimated of 2 to 2.2 grams of phosphate will be removed per week for 4 times per day, 2-liter exchanges. So again, how adequate the dialysis is will determine the phosphate. And this is one of the challenges we might be facing. We are facing in Africa, where actually some of the countries are providing only 1 or 2 times per week hemodialysis. And even in Egypt recently, where some of our patients cannot afford more than 2 times per week hemodialysis, or choosing not to dialyze more than 2 times per week or once per week. And these will definitely develop on the long-term inhibition of phosphate level. Finally, if we fail to prevent the hyperphosphatemia by diet restriction or proper dialysis, then we will have to use phosphate-lowering agents. And the one that we're going to choose, either phosphate binders, vitamin D analogs, or xenocalcet. These are the management or drug used for the CKD-MBD. So the phosphate binders, what are they? Usually we have the aluminum containing or calcium salt-based phosphate binders. Aluminum are very effective, yet they are usually used for very short-term hyperphosphatemia, and we all know that using them can cause on the long term many complications, which is mainly a dynamic bone disease. While the calcium salt-based phosphate binders are much cheaper, they are available. Also, they have good other benefits like the acid reflux and hyperacidity in these patients. Yet, we all know that with time they cause hypercalcemia, and we have to be very cautious about high levels of serum calcium, because the overuse actually, they are linked to very serious effects, especially in non-dialysis patients. Actually, there were studies where they compared calcium containing phosphate binders with a non-calcium based phosphate binders, which is sevelamer, in patients on maintenance hemodialysis, showed that coronary artery calcification occurred much rapidly in patients on calcium containing phosphate binders. So using them is inexpensive, it's effective, it's good, but we have to be very cautious about the hypercalcemia and what happens on the long term. Also, regarding the phosphate binders like sevelamer, the different types, they are very effective, they are very good, but we all know that they are much more expensive and not always available in many of the countries. But actually, when they did studies, the mortality outcome between the patients on calcium-based phosphate binders and sevelamer was comparable. So yes, it is better to try to use a non-calcium-based phosphate binders, but if you're in a place where you don't have accessibility, use whatever you have and try to control the patient's parameters as well as you can. If you talk about also the management of CKD-MBD, we'll have to talk about vitamin D analogs, where we know that there can be either IV or oral, and we know that the alpha-calcidol is a non-selective vitamin D receptor analog. And the problem is that it causes significant elevation of serum phosphorus, while the selective vitamin D receptor analogs, which are IV, will be better, but it's better because they require no liver activation, and they have less elevated serum phosphorus level. But in general, these vitamin D analogs, they are recommended to discontinue them if the PTH level is less than 100 from the fear of the development of a dynamic bone disease, which, as I mentioned, is mainly caused by iatrogenic or by doctors over prescribing the vitamin D analogs. So the routine use of the calcitriol and vitamin D analogs to prevent secondary hyperparathyroidism is being discouraged in non-dialysis CKD patients. And this was based on 2 randomized controlled trials that reported no benefit in clinical outcomes with the use of calcitriol in patients with CKD stages G3A to G5A. So we shouldn't prescribe it, especially in early and in these stages, before these stages. And again, it is recommended to stop it if the PTH level is above 100. Also, they recommended that regarding the native vitamin D, that we could, especially in stages of CKD G3A and G5D, that we measure the level of 25-hydroxycalcidiol. And if we can actually, they are low, we can use the same similar strategies recommended for general population. So we can use it if we are in these stages and we have low levels in the test that we did. These are the different types of native vitamin D that we can use, and we all know that it depends on the availability, and it depends whether you have you need activation in the liver, and the liver is intact or not. This will help us guide us for the decision of which type to choose. Finally, we have the cinacalcet, which is a calcium mimetic, which has an amazing role because actually it controls the release of parathyroid hormone because it increases sensitivity of the calcium sensing receptors which are present on the parathyroid hormone, and thus lowers the PTH level immediately post-administration. We know that usually the dose which is given is 30 milligrams, and then we titrate it upward according to the response of the patient. We know that the cinacalcet made a revolution in the treatment of CKD-MBD because it was a very good alternative in the treatment of secondary hyperpara. And it was good because it resulted in the concerted efforts to avert the hypercalcemia and the hyperphosphatemia, which is induced by the use of large doses of calcium-based phosphide binders in combination with calcitriol and vitamin D sterol. So it was good that it allowed us to control the PTH level, especially when we have high phosphorus and high calcium. But cinacalcet causes hypocalcemia. So we have to measure the calcium level before prescribing cinacalcet. We cannot. And when we are prescribing it, we have to make serial measurements of serum calcium to see how things are. So again, our treatment strategy of the renal osteodystrophy depends on the stages of the chronic kidney disease. In general, throughout the different stages, we have, of course, to monitor the calcium, phosphorus, and the PTH. We have to evaluate the vitamin D status and treat it as necessary. We have to treat the acidosis, which is very important. And we have to start very early, and especially until the CKD stage 3, as restricting the phosphorus in the diet and the beginning of the stage. Once we are in CKD stage 4, we can then consider adding active vitamin D sterols, and we have to restrict the calcium intake. And then in the later stages, CKD stage 5, we can add different medication like phosphate binder, calcium mimetics, have a specific calcium regimen where actually we can adjust the phosphorus in the dialysate or the calcium in the dialysate. And if we have also secondary hyperparathyroidism not responding to medical treatment, we can consider parathyroidectomy according to the different indications that we are all aware. This is a slide just summarizing the different approaches pre-dialysis CKD-MBD, which is actually pretty nice, and I thought of putting it. And I have to mention rapidly about also specific point about osteoporosis, because osteoporosis, as we know, it's like we have in this diagram TNT, which is going to make an explosion in the bones with fractures. And when it happens to our patient, it has a very high morbidity and a high mortality in our patients. And we know that when we approach in general osteoporosis, we have to stimulate bone formation and inhibit bone resorption, or do both according to the different strategies which are present. But what shall we do in CKD-MBD? Well, as we mentioned, CKD-MBD, we have a specific strategy which was recommended, where actually when the GFR is less than 60 ml per minute, we try to make clinical risk factors for fractures. We try to assess the risk for fractures in this patient, especially the patient is older in age, postmenopausal in women, who had a previous history of fractures using steroids or has a low body mass index, then we, as we said, recommend to make a DEXA scan, and we prefer to do it every 2 years. And according to the DEXA scan, if it is less than 2.5, then we have most probably have osteoporosis and we have high risk of fracture. Or if it is more than 2.5, then we are more on the osteomalacia side. And then the fact that we had or we didn't have a fracture in the past history will help us in determining what's going to be done next. So we did the DEXA scan with these different readings, but as we mentioned, we're going to treat the patient for CKD-MBD. And it's very important in this stage as well that we tell them to have lifestyle interventions. And the major lifestyle intervention will be physical exercise. Physical exercise is one of the few processes which actually will both prevent the resorption and also increase the bone formation in osteoporosis in all patients, whether it's a normal osteoporotic patient like postmenopausal and in CKD-MBD. So it's very important to promote physical activity for patients with CKD, even those on dialysis, by using different weights and resistant exercises, because this helps great time to diminish the chances of osteoporosis. So once we did that and we did the DEXA scan, the question is, especially if the T-scores is less than 2.5, minus 2.5, which is osteoporosis, or it's more or in this area, but with a past history of fracture, then we are considering to use biphosphonates, and shall we use the rest of the osteoporosis medication? This is the question we have to ask ourselves. And this is the recommended strategy to approach. If we are we have a patient who is in CKD grade stage 1 or 2, and with absence of the usual biochemical abnormalities of CKD-MBD, then we'll consider him just an osteoporosis patient and we'll treat him as any one of the general population. But if we are in a stage of CKD grade 4 to grade 5D with presence of the abnormality of the CKD-MBD, then we have treatment shows to take into account the magnitude and reversibility of the biochemical abnormalities and the progression of the CKD, and we should also consider to take a bone biopsy in this stage. If we are in the middle from G3A to G3B, then it depends then on the presence of biochemical abnormalities. If they are absent, then we'll treat it as the early stages. If they are present, we'll treat it as late stages. So we might consider to take a biopsy if we have these abnormalities in these patients. And also we can also take our decisions not only on the level of the bone marrow density, but also whether or not the bone-specific alkaline phosphatase level and presence, how it is. So for us to try to assess the bone turnover, either we have the bone-specific alkaline phosphatase, which is higher than the medium, which is high, with an association of elevation of PTH, then we are going to prescribe definitively, because we're talking about a high turnover bone disease, an anti-resorptive agent. But if on the other side, the bone-specific alkaline phosphatase is low with a low PTH, then we're talking about a low turnover disease, and we are going to consider prescribing an anabolic agent. But if we are in the middle, if the alkaline phosphatase is in the middle, and also if the PTH is in the middle, and we are not sure we are talking about which area, then it's very important to take in this stage a bone biopsy, because giving biphosphonates to this patient and assuming that he needs treatment for osteoporosis can actually cause a dynamic bone disease. So in this case, a bone biopsy is indicated, and usually they give teriparatide or abaloparatide in these cases. So if we look at which agents we're going to choose and are safe, usually with low GFR, these are those which are recommended to be used in the CKD patients, which are alendronate, ibandronate, risendronate, and the teriparatide. These were proved in several studies that they are safe, and they are suggested if we decided to use these different agents. And a very interesting factor, as I'm going to mention again, as I mentioned, that some of the bone rebuilders which are suggested for the treatment of osteoporosis is anti-sclerostin antibodies. I'm going to talk about them. As I mentioned, sclerostin was involved in the bone resorption, so giving antibodies against sclerostin is one of the suggested therapies to deal with osteoporosis. And when you look at the summary of the 2017 KDIGO guideline, there are still many questions raised and which need lots of studies and answers, like the diagnosis and management of calciphylaxis, and what are the effects of physical function, which is very important. Exercise needs more and more studies. Also, what is the influence of gonadal hormones in male and in females, and the impact of amenorrhea in premenopausal females? And also recommendations regarding monitoring of magnesium level, because many patients were found to have low magnesium, and how is it affecting the bones? So many questions are still raised and needs to be answered in the future. And regarding emerging novel treatment for CKD-MBD, we have iron-based calcium-free phosphate binders. They are introduced into clinical practice as a new class of phosphate binders. We have something called sacroferric oxyhydroxide and ferric citrate. Both have been shown to be as effective as sevelamer carbonate in lowering the serum phosphate in CKD-5D. In addition to their phosphate-lowering effect, they're also effective in correcting anemia in CKD and attenuating vascular calcification. Also, one of the emerging novel treatment are exogenous recombinant clotho, which may serve as a prophylactic or therapeutic therapy for preventing and reversing secondary hyperpara. It precludes acute kidney injury to CKD progression. It was found in the recombinant alpha clotho. It was also found to protect the heart from cardiac remodeling, and the post-acute kidney injury model. It was found to attenuate cardiac remodeling in CKD, and it was found also to restore endogenous alpha clotho level along the cessation of exogenous alpha clotho therapy. But all of these were also experimental in mice, and it was not used yet in human beings. Also, regarding emerging novel treatment therapy, we have anti-FGF23 monoclonal antibodies, which is burosumab, which was suggested to neutralize the detrimental effect of high levels of FGF23, and this was evaluated as well in animal models. Although the neutralization of FGF23 was characterized by improvement of secondary hyperpara, but also it was associated with increased level of serum phosphate and aortic calcification and higher risks of mortality. Thus, again, though it was very promising, the therapeutic applicability of the FGF23 antibody in humans is yet to be established. So we're not sure yet or not if it's going to be effective for CKD-MBD. Also, the clinical utility of anti-sclerostin antibodies was suggested. As you can see, what they did is that in the first diagram on the left, we have WNT that cannot work because we have the sclerostin and DKK1. And when they used antibodies preventing their action, the WNT1 could work, and at the end, we had the increased bone formation. And those which was suggested were romosozumab and blosuzumab. And several human studies have demonstrated that inhibition of the sclerostin with specific antibodies results in a rapid but transient anabolic response to the skeleton without concomitant increase in bone resorption, with impressive increase in bone mineral density and bone strength. Finally, since I talked about FGF23, I have to talk about a study that my colleagues and myself did in Cairo University, Dr. Mahmoud al-Naqiti, Dr. Mohammed Farwad Higazi, Samah Abu Zaid, and Ahmed Faid, Dr. Ahmed Faid, some from Cairo University and some from other institutions in Egypt, where actually what we did was to study the impact of the treatment of hepatitis C, the eradication using interferon-free radical antiviral treatment, and how this affected many parameters, including the bone mineral parameters. Actually, we all know that hepatitis C was linked to higher mortality in hemodialysis, and also we wanted to see if the eradication of HCV would affect biochemical parameters, including the calcium, the phosphorus, the parathormone, and the FGF23 as the CKD-MBD parameters, with other parameters also present that we detected in this study. It was done on 334 adults on regular hemodialysis with positive HCV genotype. And many parameters were assessed in the follow-up. And what was found is that actually after 6 and 12 months from the treatment eradication, there was a significant increase in serum calcium, despite no change in the oral calcium dose requirements, a significant increase in the hemoglobin, serum iron, reduction of the ferritin, phosphorus, parathermone, and FGF23. And also the fasting insulin level and the HOMA-IR also were significantly dropped. So this shows that just by treating the hepatitis C eradication, this caused improvement of the inflammation, and this by itself improved the CKD-MBD. So we didn't even have to give management, direct management, by treating the underlying pathology. This helped in improving the bone health in these patients. Another study that we did also, we're trying to use a more sophisticated way of imaging to see the bone density of the mandibular osseous changes in patients in the Qasr al-Aini. This is also a study that I participated in. And the conclusion is that actually that it didn't actually reflect on the accuracy of the diagnosis, and using the convenient or the old ways of imaging actually were much easier, and we didn't need very advanced and sophisticated imaging to assess bone mineral density in this patient. So, ladies and gentlemen, thank you for actually bearing with me. It was a pretty long presentation, but I tried to cover the major points. The conclusion is that vitamin D is both a vitamin and a hormone. It's subject to a complex interaction with other hormones, including PTH, FGF23, clotho-renin, insulin, and others. While vitamin D has been typically linked to bone health, its receptor is widely distributed in many other tissues. This translates into many functions for vitamin D in extra-osseous tissues, including cardiovascular, immune, and hematopoietic, as well as the integrity of the cell cycle at large. The kidney talks to the bone, usually asking for help in regulating phosphate excretion or acid-base balance. The bone responds either by secreting its phosphaturic hormone FGF23 and or releasing its minerals into circulation. The parathyroid gland assists and catalyzes the bone response. The tone of this physiological talk becomes too loud in renal failure, leading to adverse effects on bone itself, the bone marrow, blood vessels, and the heart. One of the largest targets of the CKD management is to reduce or abolish these adverse effects by accurate evaluation and targeted treatment, like the anti-clotho FGF23 and sclerotine antibodies. This is regarding the future. But in general, we know that the fracture risk is very high in CKD patients, and DEXA scan is suggested by the KDIGO for fracture assessment in the recent guidelines. We diagnose osteoporosis when the T-score is less than 2.5, or in the presence of fragility fracture, whatever the T-score is. The FRAX predicted the risk for major osteoporotic fracture and hip fracture in all GFR strata, so we better use it in the clinical settings. Lifestyle intervention in CKD-MBD management are important to decrease the fracture risk, so it's very important to have proper nutrition. Important. In absence of biochemical abnormality for CKD-MBD, we treat osteoporosis as the general population. In presence of these abnormalities, with treatment choice to take into account the magnitude and the reversibility of the biochemical abnormalities and the progression of CKD. And it's very important to know the type of bone turnover before starting osteoporosis medication. Bone turnover can be detected by lab markers, but bone biopsy may be needed if diagnosis is not clear. And in case of high turnover disease, we use anti-resorptive agents, and in case of low turnover disease, we use anabolic agents. And I will conclude that at the end, we need, especially for CKD-MBD, and this is a recommendation of the KDIGO, not to work alone. It is a multi-professional decision-making where we have nephrologist, rheumatologist, radiologist. We all have to work together and to brainstorm to be able to take the proper decision to improve the lifestyle of the patient and to diminish the morbidities and the mortalities. And thank you so much.
Thank you so much, Dr. Rasha, for this very comprehensive, illustrative, and inclusive talk. Nearly a revision for a big topic that needs many sessions, but you did it really in one session, and thank you very much. and Professor Amr Al-Husseini. So please.
It's very outstanding. I teach this topic in 32 weeks and I cannot even cover it, you know.
Yes.
It's very amazing. You cover everything, diagnostic, you know, starting from the basic knowledge, pathogenesis, diagnostics, and the management, just in 1 hour, 10 minutes. Actually, your ability to communicate such complex issue with a clarity is just truly amazing. Your presentation was not only informative, but also incredibly well organized and structured. I think it made an insight with a significant impact.
Thank you so much.
I'm very happy, you know, seeing you as one of the expertise in the field, because we need expertise in this field in Egypt and in the Middle Eastern region and in the developing countries, because this problem, the CKD-MBD problem, is huge and has significant consequences, of course, very, very bad consequences in our patients. So I'm very happy to see you, you know, with this passion and talent regarding this issue. Thank you so much for your presentation.
Thank you so much. Appreciating really words, especially coming from you, Dr. Really, thank you so much. I appreciate
Thank
it.
you so much. Thank you so much, Rasha, and thank you so much, Dr. Amr. Dr. Amr, I want to ask about your experience in use of recent drugs, anti-FGF23 and anti-sclerotine therapy. Do you about your experience? Did you experience the use of these drugs in USA?
Very nice question. I rather like to use non-pharmacological approaches first. I don't jump to such expensive medications that comes with a price, not only with a cost, but also, you know, with side effects and adverse events. I rather encourage my patient first to eat healthy, to have better lifestyle, healthy lifestyle, to exercise, to control their hyperphosphatemia and CKD-MBD disorder with non-pharmacological intervention. This has been proven to be very effective, cheap. It doesn't only improve the bone health, but also improve other, you know, cardiovascular system and other organs as well. When it comes to the new interventions like anti-sclerostin anti-2, you know, anti-sclerostin antibody and FGF23 antibody, it is not very well studied in advanced CKD, at least, you know, on dialysis especially. Anti-sclerostin antibody, the romosozumab, has potentials to increase cardiovascular calcification. There was warning about this even in general population, and because of our CKD patients, it's a huge problem, so it might have more concern. However, I came across a couple studies that was published from Japan last year and this year. It showed some, you know, confidence and safety. They didn't really random the patient and follow them up and did the cardiovascular calcification studies, but rather they were talking about the MACE, the major cardiovascular outcomes, the mortality, having to change it over 1 year with using romosozumab. Again, we need bigger studies. There is no guidelines to use such medication yet in dialysis patients, at least. Borosozumab, the anti-FGF23 antibody, is a little bit tricky because FGF23 elevation starts as a compensatory mechanism because it's a phosphatory hormone. So it's actually helpful at the beginning of the CKD because it helps to prevent hyperphosphatemia. This is the reason that we don't see hyperphosphatemia early in our CKD patients. However, later on, it changes from adaptive to maladaptive, from compensatory to a pathological biomarker. So using it in CKD patients prior to dialysis might not be a good idea because it will induce actually hyperphosphatemia with its bad consequences. However, its usage in dialysis patient might be a good idea. I have talked to several investigators trying to conduct such a study, but so far its use in advanced CKD patients has not been, confirmed, not either proven. So I think it's too early. Again, these are very expensive medications. It has, the safety and efficacy in our advanced CKD patient is not very well studied and not yet proved.
Thank you. We have many comments from professors and questions on the chat, but I want to ask a question for me first and leave it to you, to Professor Amr and Dr. Rasha, about the use of sevelamer in pre-dialysis patients. What's your opinion in this point? Who can help me for this?
Amr, go ahead, Dr. Amr, please.
Okay, yeah, I'm giving Dr. Rasha. I saw that she was tired by the end. I mean, I don't know how she did this. It's very, very big task. But yeah, I will just keep talking just to give her a break. I like to learn and listen to her. Dr. Hisham, do you want to say something? I think Professor Hisham wants to speak.
Can you answer me of this?
Yeah, of course. Yeah. So the use of so as we mentioned early on, it's very rare to see hyperphosphatemia in CKD stage 3A, 3B. It might start to happen in stage 4. Again, Dr. Rasha emphasized on two things. First, we are not targeting to normalize the phosphate level. We are looking to the trend as long as we can control it and that, the phosphorus is going down, say, from 6.5 to 6 to 5.5. That should be fine. We should be happy. We are not looking for a certain number because the older KDIGO recommendation, the 2009, was trying to recommend or suggest at least to maintain the serum phosphorus level within the normal level, but there was no evidence based on the studies. So the updated...
I'm sorry, I have lost internet for a while.
Yes, sir. Go ahead, Professor Hisham.
Okay, thank you very much. I'm still have a conflict about...
I'm afraid that you still have a problem, Professor Hisham, with the internet.
Please continue, Professor Amr. Please continue, Professor Amr.
Thank you.
Please
so,
continue.
yeah. So again, the use of phosphate binder. Before we talk about phosphate binder, I don't want to jump to, again to medications. So we try to control it with diet. Modification of diet is very important. Especially, we need to see not only the quantitation, but also the quality, because some bioactive phosphorus in the inorganic forms, is very high. So we need to review with the patient, what they are eating. We usually say to the patient, not only we are what we eat, but we are also what we eat. So it's complicated because you look to the chicken, you look to the farm, and if they are raised in cages, and if they are not moving, and if they don't eat healthy, also what we are going to eat is not going to be very helpful. So it's a big discussion. So yeah, if I fail to control this, usually doesn't happen except in advanced CKD. And actually, it might be an indication that this patient might need dialysis, okay, either peritoneal or renal replacement therapy option, because this doesn't happen at least early. Even if it happened in CKD stage 4, I think I still can control it with non-pharmacological intervention. And yeah, of course, I can use it sevelamer or other, either calcium-based or non-calcium-based phosphate-lowering therapies we can use prior to dialysis if we feel other non-pharmacological intervention.
Thank
Do you
you
agree,
very much.
Dr. Rasha?
Professor
Yes.
Hisham? Rasha, Dr. Rasha?
Just the concern of the expenses. I mean, at the end, we have to look at the fact that these are very expensive in our countries and they are not available for everyone. So I think prevention should be the major target. Just to talk and to educate the patients about how to prevent and to have proper nutrition is better than waiting till the phosphorus is high and try to find the money to provide the medication. This is my point of view.
Thank you. Professor Hisham?
Sorry again for the internet. So I asked it a simple question and I understand that it has a very long answer. According to polyspecific alkaline phosphatase, we didn't find any changes with hemodiafiltration, although the sclerostin level dropped. So can I have just a summary? Is it good to remove or not sclerostin?
I didn't, you said the alkaline phosphatase and then you said sclerostin, Dr. Hisham. I didn't understand the question.
Yeah, in our clinical study, and I presented that orally in annual dance conference in Dallas, we patients on hemodiafiltration showed significant drop of serum sclerostin with time, although for specific alkaline phosphatase did not change.
Okay, interesting. Well, actually, as Dr. Amr said, sclerostin for sure, it was connected to increased bone formation. So the diminishing of the sclerostin was proved in several data that improves the bone. But the concern, as far as I know, is related to the present calcification, which was found to happen due to an internal mechanism. So as far as the studies, it should be useful to inhibit sclerostin regarding the bone, and we should have a reflection on the alkaline phosphatase. But I'm sure that your finding is interesting. Maybe the fact that it was removed but still present caused that, Dr. Hisham, because what they were suggesting, sclerostin was abolished by giving antibodies directed against it. So maybe it was totally annulled, but maybe
you understand that you know that the dynamic process of the hormones and the other biochemicals and the biomarkers in the body and the blood are changeable with dialysis. This does not mean that in a dynamic way, for example, PTH, very small molecule, it's 11,000 Daltons, removed easily by hemodialysis and hemodiafiltration, but never to be a way of therapy because it's a very dynamic process. So production is increased. The only process inhibitory is the dialysate calcium rather than the technique of dialysis. So to my understanding that...
Professor Hisham, one second, give me an interaction here before you leave this point. So
Yes.
what about the measurement of PTH in dialysis patient that we usually do?
So let me emphasize on
dialysis can remove parathyroid hormone because it's a very small molecule and could be removed. The problem is the gland is very dynamic, so hemodialysis is not a way of treating hyperparathyroidism. The importance is the dialysate calcium. High dialysate calcium will suppress the parathyroid hormone, but on the other hand will do positive calcium impact. That's my say that for the PTH. Do you want to comment, Professor Yasser?
Professor Amr.
Wow, thank you so much, Professor Hisham. Yes, I agree with you. It's not only about the molecular weight or molecular size of the molecule we are looking also for the how long this molecule stay in the serum. What is the half-life of the molecule? So when it comes to the BTH, it's about 5 to 7 minutes. So whatever you do with dialysis, right after the dialysis, 10, 15 minutes, everything will be back to the baseline. So we are not looking to control hyperbara by dialysis because it's very, very short half-life. Sclerostin, sclerostin is 20, I think 22, 23 kilodalton. So it's, I see that it can be removed, but again, it's, the formation rate is very high, especially in dialysis patients. The problem that happened in dialysis patients, and Dr. Rasha mentioned this, they have what we call osteocyte dysfunction. Osteocyte. The osteocyte is a major endocrine organ. The osteocyte secretes sclerostin, secretes FGF23, secretes activin, secrete also a lot of TGF-beta and interleukins. So in patients, in our dialysis patients, they have their osteocyte start to produce a lot of these cytokines that inhibit bone formation and stimulate bone resorption. The combination, and I usually emphasize on this, the combination of diabetes, CKD, and sedentary life or immobility or inactivity or absence of physical therapy is these are the patients who live very short. They have what we call premature aging and senescence. And this is a problem. I see a lot of questions in the chat box about why this doesn't work, why calcium-based versus non-calcium based, how to decrease the calcification. It's senescence. Yes. Just can you get me as to convert me or to let me go back in time to be a 20-year-old guy? You can't. Same thing happened to dialysis patients. They are even if they are 20 or 30, their system, their organs are very senile. They behave as 60, 70, or 80-year-old patients. Their cardiovascular system, their bones, they have premature aging and senescence. So to correct this just by using non-calcium based versus calcium based, you don't anticipate this is going to happen. Even after kidney transplantation, we thought that cardiovascular calcification and bone disease will improve after. Is there any other alternative or option better than kidney transplantation that improves the uremic milieu? But despite that, it improves the uremic.
The bone coming very long story. Even after transplantation, you cannot reverse what's happened.
Right, and cardiovascular, calcification, you can slow down, but still they still progress. You cannot revert. So it's very complex issue. But I think holistic approach, try to control all the risk factors together. Try to work as multidisciplinary team, not only as a physician, but with the nurses, with the dietitian, with the physical therapist, with the, everyone, pharmacists, clinical pharmacists, and try to control all of these metabolic disorder, control blood pressure, diabetes, control phosphorus, control hemoglobin, gives the patient the best, dialysis. It's not only about dialysis adequacy. I heard Dr. Hisham, I learned from him.
Yes.
You need to optimize and to, not only to get, the dialysis adequacy, but there is several other. If you do all of this together, as
14 points. 14 points should be fulfilled.
Yes, sir. Absolutely. I hope they are only 14, not more than that.
Yes.
But to our knowledge,
what we know 14, yes.
Right. Thank you.
Thank you very much.
Thank you, Professor.
Good break to Dr. Rasha. I think she recovered.
Yes.
Now she can share ideas and try to answer.
Many questions about the target calcium level. One about target calcium level in post-parathyroidectomy, target calcium, PTH, and phosphorus. And the other about Oxford from Dr. Ibrahim. About Oxford, your comment about Oxford recommendation of calcium level 8.5, as I can get the question if I'm not wrong.
Which Dr. Ibrahim? Because
Dr. Ibrahim Omar, he is asking some questions. Mainly,
Dr. Ibrahim Omar asks tricky question, and he was with us in the CKD-MBD.
Yes, I guess this is one of the.
He knows a lot of details.
The target calcium level post calcium, PTH, and phosphorus post parathyroidectomy, and one is about Oxford recommendation for low calcium 8.5.
I think, do you want to answer this, Dr. Rasha?
Well, I think at the end, it's a we have to approach it from different aspects. I mean, it's not just about the level of the calcium, it's also what type of bone disease are we in at the stage of the measurement of the calcium. In general, we want to have normal readings, but we have to be very cautious on how we are doing it and what are we targeting, especially if we have the doubt and the fear of autonomic bone disease. That's what we should be focusing on when we're targeting a normal calcium level. Like at the end, we just want normal levels, whether before, after parathyroidectomy, we want normal levels. That's my answer regarding that.
Very good. By the way, the calcium in the extracellular compartment, when we assay the calcium, it's only 1 apart from 1,000, 1 out of 1,000. Yep. 99% of the calcium is in the bone. So I greet Dr. Rasha that she mentioned you need to look to the whole picture, because only looking to the serum calcium level is not going to help, because the patient can be calcium deficient or can be on a positive calcium balance, and the serum calcium level doesn't reflect either. So there is no good correlation between serum calcium level and the calcium balance. And there is a small study already showed that. So I don't think there is a magic number we need to follow. We need to see the whole picture. And this is the medicine is art, as Dr. Hisham Said usually tells us. So this is the reason that it's not a computer-based and ask ChatGPT what is the normal calcium level for dialysis patient. You cannot say that. In general, the rule of thumb is our dialysis patients are on a positive calcium balance. And of course, this is the reason for increased cardiovascular calcification. We try to decrease this positive calcium balance, but again, you have to look to the whole components, all the compartments, but we try to limit the calcium intake and the calcium containing phosphate binders. However, there is some reports that some patients, especially in developing countries, might have osteomalacia secondary to calcium deficiencies, especially when I have done several bone biopsies in Egypt. We found aluminum intoxication and osteomalacia. So the combination, if the patient is phosphate or calcium deficient or vitamin D deficient, along with aluminum intoxication, this is very easy to induce severe osteomalacia. So we need to be careful a little bit, especially this year, just this year, there is a guy who is leading the ERA EDITA CKD-MBD group. His name is Peter Evan Ball. He published 3 articles in 2023, just raising the red flag and giving some orientation about the risk of negative calcium balance. We usually thought, and I'm a fan of that, but sometimes I say maybe I'm not correct. I actually wrote an editorial article and criticize what he tried to advertise for at the beginning. But I think because he doesn't only speak for himself, but he speaks also for the ERA EDITA working group, the CKD-MBD working group. So yeah, and some again in developed countries, osteomalacia is very rare, about 1 to 2%. But in developing countries, when we did bone biopsies and we sent it to our lab, and we found huge aluminum intoxication problem from different programs, not only from a single or a specific city, but we have done bone biopsies from different cities. And anyway, and hopefully Dr. Hisham in the future can focus on this problem, because we have done also blood aluminum levels and water aluminum level from tap water, from the after the RO system, from the dialysate water and everything. And the problem is the level wasn't too high, but in the bone, it was extremely high. So that's another issue we need to talk about. So again, if we are looking for the calcium, you need to look to the whole picture. After parathyroidectomy, don't target normal, at least, please don't target. If you don't have BTH, you are not going to have, normal serum calcium level. If you give mega doses of calcium to correct, the hypocalcemia after parathyroidectomy, if you don't have BTH, this calcium is not going to stay in the blood. It's going to increase cardiovascular calcification because it's not going to go to the bone either, because of the very low bone turnover disease. So the bone is very adynamic. So the calcium you're giving is not going to the bone. And, you reassess the serum calcium level and it's not improving. So you give extra doses, and other mega doses, then everything will, go to the extravascular tissue and induce more calcification. So it's, just try to avoid severe or symptomatic hypocalcemia. So maybe 8.5, even for me, if it is 7.5 corrected serum calcium level, if it is asymptomatic and the patient doesn't have, arrhythmia, you need to, to risk stratify it, arrhythmia or neuropsychiatric manifestation, or any twitches or, any, symptomatic hypocalcemia, I wouldn't treat it, especially if the patient is a little bit acidotic. If the patient is on the alkalotic side, that's another story. So we need to, again, to look to the whole picture.
Thank you, Professor Amr, for this important point, for illustration of this important point. We have a comment from Professor Saeed Khamis and some questions from the chat. So Professor Saeed, please, one question from the chat. Professor Saeed,
Thank you, Professor. Thank you, Professor Yasser. Thank you, Professor Rasha, for this amazing, outstanding, exhausting lecture for you and for us, but for you more. But actually, it was very fruitful for all of us, actually. Thanks, Professor Amr, also for your valuable comments as usual. Just I have, if you allow me, I have two questions regarding this issue. Number one is what's called the hidden phosphorus. We know it is in the food, in the soft drinks and so, but one of the very important source is the medications. Some medications have containing phosphorus. And I don't know if there is some interruption from other audience. Anyway, so can you throw some lights, first of all, regarding this issue, regarding the medications containing phosphate?
Dr. Amr,
Dr. would you like to comment?
Actually,
Dr. Saeed, you're the one who tell us. We learned this from you.
Dr. Saeed was not with us, was not joining us the last session from Dr. Iman. She was speaking about this.
For sure, it was amazing.
She took some about 10 minutes or something like this about phosphorus and diet and medication in the last lecture about electrolyte, dietary management of electrolyte disorders. So we can ask her to repeat it again for you.
It's significant enough. Yes, medications, do they make significant changes in the phosphorus as a nutrition, or is it something exceptional with specific drugs? I mean, I would love to know that.
Yeah, it's also surprising to know that even one of the commonest medication we use, like calcium channel blockers, amlodipine and other, they have a significant amount of phosphate. So it's always important to review the medication and its phosphate content. I completely agree. And I think Dr. Saeed, he taught us this in one of his famous presentation was drug anti-kidney, and I think he highlighted this in the past. He knows the answer, but he challenged us.
Thank you, Professor Am. Thank you. Second thing is regarding the alkaline phosphatase. Professor Hisham said, can we remove the alkaline phosphatase, aiming to treat the dilemma of CKD-MBD, especially the vascular calcification? So The reverse is true, to my knowledge. The reverse is true. They are trying to give alkaline phosphatase as a drug to treat or to prevent what's called vascular calcification. I am wrong or correct, Professor Amr?
Sorry, Professor Said, I didn't say that we can remove alkaline phosphatase. I said that we removed in our study and presented orally in Dallas that we removed sclerostin, but serum alkaline, bone-specific alkaline phosphatase does not change. So my intention was to remove sclerostin, but didn't does not change the bone-specific alkaline phosphatase. I'm not looking for that in removal. Way by
Yes.
that.
As a biomarker.
As a biomarker, you mean, Professor Rasha?
Yes, biomarker of improvement or disappearance of bone turnover by removing sclerostin. We didn't find any significant changes.
Yes,
Thank you. Dr. Ibrahim Omar commented on your question, Dr. Saeed, about that TPA, heparin, liposomal amphotericin have high phosphate content, and of course, as have been mentioned by you in your lecture and Professor.
Yeah, he has the right to mention, but thank you, Professor Dr. Ibrahim. Last issue, Professor Rasha and Professor Amr, regarding the end of the spectrum, regarding hypophosphatemia. Hypophosphatemia, I think it is also dangerous and as a risk factor for CKD-MBD. What do you think about this issue and how can tackle this issue?
Well, I mean,
That's
yes,
go
I
ahead.
just say just a general thing is that as Dr. Hammer was mentioning, we have to look at the patient as a whole. I mean, we tend to deprive the patient from lots of nutrition intake. Usually the Egyptian patient comes, say, what did I do wrong? What do I have to do in my food? And we give them a list of things which are not allowed, that he's not allowed to take. But the problem is that with time, patient develop sarcopenia, and sarcopenia was actually a very strong predictor of mortality. So I think that sometimes we have to balance the general condition of the patient. We have to try not to limit excessively the food intake, which leads, for example, to hypophosphatemia, to have a better general condition, a better mass, and maybe be more flexible in the ranges of the labs. As Dr. Amr was saying, I can accept a bit high potassium if the patient doesn't have electrolyte abnormalities, but he's eating well. I mean, this is my suggestion in general in approaching these patients. Dr. Amr?
Very well said. Thank you. And yeah, I mean, we call it actually osteosarcopenia because when the patient lose muscle, also start to lose bone as well. And phosphate is very important to muscle, but also 85% of the phosphorus is stored in the bone. So 99% of the calcium is stored in the bone. 85% is stored of the phosphorus is stored in the bone. So when the patient lose muscle, they lose bone. But it's a little bit infrequent problem with advanced CKD. The more frequent problem is hypomagnesemia, or I would better say it, magnesium deficiency. Because the patient could have normal magnesium level, but still magnesium deficient. And magnesium has been shown in several RCT that it can inhibit the cardiovascular calcification progression in our dialysis patient, even if when they try to use two different dialysate magnesium, patient who was randomized to be on high dialysate magnesium, they have less progression of their calcification. The calcification propensity score went down, and also there was some improvement in their BTM, the bone turnover biomarkers. So magnesium is important, and the magnesium deficiency is a problem in our patients. And again, there was a studies that showed the total magnesium deficiency, even if the serum magnesium level is normal, it's a problem in our dialysis patient, especially with those with acidosis, because the bioactive magnesium, the free fraction of the magnesium, is much lower in dialysis patient compared to general population. So magnesium is, I think, is a very important co-player for at least for cardiovascular system. When it comes to the bone, still not very clear what does magnesium do for the bone. We are still studying that, but it's very clear when it comes to the cardiovascular calcification.
Okay.
Thank you once again.
ma-
Thank you, Professor Rasha, Professor Amr, Professor Yasser, and Professor Hisham. And actually, we are lucky to hear from you tonight. Thank you so much.
Thank you, Professor Saeed. Thank you for being with us. Usually, many questions on the chat. I can collect simply on one question from Dr. Khalid Abu Zaid, from Dr. Professor Manal Deep, about the use of teriparatide in dynamic bone disease and its role in general. Do you find its role is an actual role in general, and do you recommend strong use in this case? This.
Yeah, again, we love in Egypt and developing countries, we love the expensive medications.
Very
Ah.
expensive.
We love the novelties and new technologies. Again, I mean, you can use it, but at least try to minimize. First of all, prevention is better than cure. So most of our patients, they end up by having low turnover bone disease because it's iatrogenic. We usually over-suppress the BTH either medically or surgically. And the problem after parathyroidectomy is huge and very, very hard to, correct. So try to at least prevent this from happening. If this happens, we need to use lower dialysate calcium. We need to minimize the calcium intake either in the food or also in calcium-containing phosphate binders and others. We need to stop the vitamin D analogs and, of course, the calcium sensing receptor agonist. If we fail to do all of this and putting the patient on lower dialysate calcium, if this doesn't help, and if the BTH is, stay very low, and there is an evidence of bone loss, so it's not only we are not treating hypocalcemia, by the way, or we are, treating surrogate marker. We are treating the bone. We are treating the low turnover bone disease by the teriparatide. Because actually it might not be helpful for hypocalcemia, and I can tell you why. That's basically because if you are building a bone, if you're helping the patient to build up bone by giving teriparatide and to let their bone more awake, it's going to take more calcium to build up newer bone. So anyway, you don't anticipate that you are giving teriparatide to improve the problem of hypocalcemia, but you are giving it to improve the adynamic bone disease. And you should have parameters to follow this up. So you do at least the DEXA scan, as Dr. Rasha mentioned. Then you follow the DEXA scan, not at least before 6 months or a year. So this is a long time to give daily injection. So you should also follow the BTM, the bone turnover marker, to make sure that there is bone formation marker and there is bone resorption marker. Bone formation markers, basically the most widely available one is the total alkaline phosphatase. If you can do bone specific, that's good. If you can't, just use the total alkaline phosphatase. Make sure that the total alkaline phosphatase is going up. This means that there is more bone formation. On the other hand, the TRAP5B that was mentioned by Dr. Rasha as bone resorption biomarker can be used. So you have two wings, one bone formation or bone resorption biomarker. You can use this to follow on the response of the teriparatide, and at least annually you need to do the DEXA scan. The last thing is there was a concern about developing osteosarcomas. It was an animal studies, but the US, the FDA approval limited in the past usage of teriparatide to 2 years. The European approval was for 3 years. Now they took out this limitation because there is no human evidence of developing osteosarcoma or other type of cancer with the teriparatide.
Thank you, Professor Amr. Of course, very big topic. We have addressed many of it, and you tackled this point of low turnover bone disease many times, and with me in a specific time about 1 or 2 years ago, and we are expecting to have many meetings
You
concerning
don't
this.
lead me now. You just you have you know, a national figure now. Dr. Rasha can do this job.
You are
I got bunny eggs. I got bunny eggs from sitting 2 hours. So
I know.
Very well.
I just have a question, a final question to Dr. Amr.
Let me, Dr. Rasha, let me tell Dr. Hisham something. You got only bony egg. I got muscle loss and bone loss, osteosarcopenia. Okay.
We are all very young and healthy.
I have a train some hours later.
I just have a small question for Dr. Amr that some of my younger colleagues mentioned that I found interesting, that he said that he found that many of the cases, he found that one of the cases with adenomatous bone disease turned out to be not due to iatrogenic reason, but actually iatrogenic for another reason. By repeated blood transfusion, the patient developed hemochromatosis, and this was the reason for adenomatous bone disease, and the treatment for this patient was by doing chelation, by doing chelation. And this was very interesting for me. So would you doubt it if the patient had, for example, other manifestations of hemochromatosis? Do you see that in the States? That's my question, Dr. Amr.
Yeah, that's very good. That I don't know who mentioned this. That's very smart. Yeah, we stain actually for in the bone.
The MD exam. His name is Dr. Islam. He's one of our younger colleagues, so we have to congratulate him for passing the exam.
Yeah, very nice, very nice. So we don't only stain for aluminum, but we also stain for the iron in the bone biopsy. So one of the basic workup we do is we stain for the iron, because we are very aware that the osteomalacia can happen not only because of the aluminum intoxication, but also because the iron overload. It's not very frequent. As I mentioned, in the developed countries, it's only 1 to 2% the prevalence of osteomalacia, whatever the reason is. But of course, we don't use blood transfusion very commonly here. Almost every patient have access to the erythropoietin therapies and the newer, anemia managements. But maybe it's different practice in Egypt. Maybe I'm not very aware. But when I was there 2 decades ago, it was very common practice to give blood transfusion. And also you might overload with iron and stuff. So we have to be careful. I completely agree with that.
Okay.
Thank you. We are to close. We are to close
2
now.
hours.
This very long journey, very interesting journey. So thank you, Dr. Rasha, for this very interesting lecture. Thank you. Thank you, Professor Amr, for your usual very comprehensive and very illustrative share. And it was another talk. This discussion was another talk regarding CKD-MBD. So we have 2 talks, Dr. Rasha talk and Professor Amr talk. And we will not close this session. We can extend up to, I think, midnight or more. Thank you very much. Thank you for all professors who attended the session and shared us with all valuable comments and valuable discussions, and for all attendees for their highly tricky and highly significant questions that enriched us and stimulated this discussion. Again, thanks, Dr. Abdurrahman Maghrabi, for your all care, and thanks, Dr. Islam. He is one of our coordinators for the last tricky question, and he will be the coordinator of the next session. Excuse me to close this session. تصبحوا على خير, and meet you next Wednesday inshallah in the coming meeting of Egyptian Society of Nephrology and Transplantation. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. شكرا جزيلا. شكرا.